Okay, I think we're going to get started here. We'll give it a little bit of time for all of the attendees to join. Good morning, everyone. Welcome to today's Wolverine Caucus. Thank you very much for joining this virtual opportunity to hear more from University of Michigan experts on maternal and child health outcomes. I am Rebecca DeVoe and serve as the Director of State Relations in the Office of the VP for Government Relations here at the university. For those of you joining as participants, welcome to our virtual Wolverine Caucus series for 2021. The caucus has been in existence for over 20 years, providing a forum for Lansing U of M alumni, as well as legislators, lobbyists, staff, and advisors working in and around the state capitol in mid-Michigan. The Wolverine Caucus hosts a luncheon in Lansing traditionally, and we cannot wait for those to continue soon. Our programming features U of M experts on timely, relevant public policy issues during the legislative session. Our mission is to provide diverse forums where views can be exchanged and everyone can hear from faculty and administrators. Before I introduce our panel, I'd like to run through some quick housekeeping items. First, this webinar is being recorded. If you do have questions for any of the panelists, please use the Q&A feature to ask your question. You do not need to digitally raise your hand. The Q&A feature will be monitored by myself and staff. We will conduct the Q&A following the presentations. A reminder that in this webinar, attendees cannot see each other. Attendees can only see the panelists. As panelists, we cannot see you. With quite a few people on the call, we unfortunately won't get to all of your questions, but we will do our best to try and answer through email follow-up. So with that said, let's get started in introducing our panelists. Our first panelist will be Dr. Vanessa Dalton. Dr. Dalton is the Associate Chair of Research in U of M's Department of OBGYN and is the Director of the Program on Women's Healthcare Effectiveness Research. Clinically, she is focused on reproductive health, and her research is focused on the impact of public policy on women's health. Our second panelist is Dr. Maria Music. She is an Associate Professor in the Department of Psychiatry and OBGYN, and she is also heads up the Women and Infant Mental Health Program, as well as Zero to Thrive. Her expertise is in women's mental health, focusing on pregnancy and postpartum. Our third panelist, Lynette Berry, is the Strategic Director at Michigan Medicine in the Department of Psychiatry for the Zero to Thrive program. Zero to Thrive combines research, training, and community initiatives aimed at improving the health and well-being of families from pregnancy to early childhood. Some of you may recognize Ms. Berry from her previous role is the Zero to Thrive Director in the Department of Health and Human Services for the state of Michigan. Finally, our panelist is rounded off by the Executive Director of the Michigan Council for Maternal and Child Health, Amy Zagman. The council is an organization of diverse partners comprised of health systems, statewide organizations, local public health advocates, and individuals with an interest in shaping and influencing state policy related to the well-being of women, children, and families. So with that said, I will turn it over to Dr. Dalton to begin her presentation. Thank you, Dr. Dalton.
Thanks. I will need just some confirmation that I am sharing screen and it looks right. Okay, great. Well, thanks very much for inviting me today. And actually, I must say that I'm stepping in for my chair, Dee Fenner, who was otherwise planning to be here, but had something else that came up. I wanted to start with just reviewing what our department's mission, which was updated when she stepped in as chair. And the mission of our department was really important to us, and we spent a lot of time and had a retreat to develop this. But it's improving improving the health and well-being of women everywhere through clinical excellence, compassion, and inclusive care, discovery, innovation, and education. I think this year has been a particularly challenging year for everybody, but has been particularly challenging for us for a variety of reasons, but one of which is in addition to COVID, we were kind of taking on some pretty big visionary challenges, I would say, in terms of how to reorganize our healthcare. And as part of this, during one of our retreats this year, we had faculty get together and talk a lot about the things that were important to them. And the main theme really that came out, no matter what the clinical context was concern about disparities, concern about equity, and how our department can engage with other units in the university, in our community, and around the state to improve health for all women, and especially pay attention to what is now become clearly a focus for many, is the just alarming rates of disparities in racial and income and geographic disparities in maternal health. So I will focus most of what I'm going to say today about what our department has focused on in that context. But I just wanted to sort of point out that I absolutely can't touch on everything. I am, as by way of introduction, I'm Vanessa Dalton. I've been in the department for over 20 years. My area of focus was mentioned is looking at the impact of policy on women's health. We are particularly interested in looking at policies that promote equity, reduce healthcare costs, improve women's health and well-being. Some of the work that we've done, and I'm just sort of going to highlight some of these things, but a lot of the work that we've done is looked at healthcare reform, in particular the Affordable Care Act. This is just an example of some of the more recent publications or studies that we've completed. And one was looking at the contraceptive mandate, which I'm always kind of struck by how little language there is in the Affordable Care Act about the contraceptive mandate, yet in the public sort of discussion, this is one of the big topics. And we looked at a couple of things. One was amongst commercially insured women who otherwise there is some income variability in women that are enrolled in commercial insurance, and it provided an opportunity to really look at how removing out-of-pocket costs for contraception would change behavior around contraceptive use, but also what we're ultimately interested in is how is that related to births. And the connection there is that most births are in this country are close to most births. Let me back up. Almost half of births in the United States are unintended. And so you assume that changes in birth control are actually reducing unintended births. And if you believe that, then, I mean, this first panel just shows you changes in contraception non-use, meaning you not using a prescription method over time. This is about the time that the contraceptive mandate took effect. The top dark colored bars are lowest income women, which is we define as people whose households were at 400% of the federal poverty level or less. And this is a middle income group and a higher income group. Basically what you show as, particularly amongst those in households in this lowest income category, non-use of contraception declined more rapidly after the Affordable Care Act, and more profoundly amongst women in households with the lowest income. And then the second panel shows changes in births, and you see exactly the same thing, which is that births, particularly amongst women in the lowest income households, declined more rapidly following the Affordable Care Act. And again, these are all women enrolled in commercial health plans that were impacted by the contraceptive mandate. Other work that we have been, and actually our next speaker, Maria, is on this team, has focused on looking at perinatal mental health conditions around the time of pregnancy. Over this summer, we published a paper that looked at suicide ideation amongst women around the time of pregnancy. over time. And the concerning thing that we found was that ideation and self-harm have increased significantly in the last couple of decades among women around the time of a pregnancy. And what's not shown here is that increase is more profound amongst Black women. And this got some really a boost of attention more recently after Meghan Markle's interview with Oprah. And I just wanted to show this is the beginning of some broader work that is funded by the NIH, looking at the impact of policy, including parity and the Affordable Care Act, on diagnosis, treatment, and health outcomes related to perinatal mental health conditions. So another area of work that we have that we're engaged in is looking at financial toxicity of birth for families. And for each of these slides, I try to put a new face on here. This is Michelle Moniz. Michelle has led a lot of this work. She's a health services researcher. This work, what we discovered is, following the Affordable Care Act in particular, out-of-pocket costs for deliveries or births has increased substantially, largely related to the increase in the number of plans that have deductibles. And at this point, giving birth costs families more than a US woman earns in a month, and continues to increase. And the absolute number is about $4,500. Michelle is doing some additional work looking at credit in the year following birth to determine whether or not this financial burden has longer-term financial impact on the health of families. And also things like whether or not, because of these potential debt, do people change their use of health services otherwise for both mom and the newborn. Another one of our researchers is Lindsay Admon. She is also early career. Her interest is in looking for policy solutions to reduce disparities in maternal morbidity and mortality. She's particularly interested in looking at disparities in insurance churn around the time of pregnancy, and how policies, for example, looking at Medicaid eligibility, Medicaid expansion, and how these policies might impact disparities in maternal morbidity and mortality. Another young faculty person, Sarah Compton, she has a PhD in health management and policy, and she has just been recently funded to look at Title X and community health in Michigan. Her background actually is really interesting. Most of her work was in sub-Saharan Africa, and for lots of reasons would like to transfer some of her work to the United States, which obviously there are a lot of areas in the United States that have low resources. And so some of the work that she's been looking at is the healthcare safety net. In particular, Michigan was sensitive to Title X regulatory changes because so much of the Title X program was subcontracted to Planned Parenthood of Michigan. And she has begun to look at the impact of changes in the number and the capacity of Title X clinics in service delivery and some health outcomes. This is just some preliminary work showing that each of these dots is a Michigan county. This is statistically significant. I didn't put any of the numbers on here, but basically what it shows is that for Title X clinics, the increasing proportion of patients that are eligible served in a county is strongly associated with decreasing teen pregnancy rates. And this is cross-sectional. There's lots of work that needs to be done here, but I think this her work will be very informative in our understanding how publicly funded health centers can improve community health. Another area also prompted largely by COVID, but has been something that's been in the center of discussion and amongst those of us that take care of women during pregnancy is prenatal care redesign. This is Alex Peel. She is also an early career health services researcher in our department. Her interest is looking at redesigning our prenatal care programs to be more individualized. These programs can be tailored to an individual's medical, social, and structural needs. This is just a list of the kinds of assessments that she is studying to determine whether doing this, what we call like right-sizing prenatal care plans to individual patients, can address disparities in maternal and infant outcomes. This is Molly Stout. She is our new division director in maternal fetal medicine. Her interest is in preterm delivery. She has two relatively large studies. One is looking at a device that is really novel, that would help us predict when women are at risk for preterm delivery, which has been a challenge in as long as I've ever been an obstetrician. And then the second is looking at doing some translational research, looking at the vaginal microbiome and the maternal immune response and how that is also associated with early delivery. Our department, also headed by Dr. Stout, has what's called a biorepository. What this is a collection of biologic samples, and it's linked to some clinical data from over 1,000 individual pregnant women. And these samples are available to researchers interested in looking at a variety of questions around the time of pregnancy. And then lastly, I wanted to talk about something that was really important and relatively new for our department under D, which is really creating more robust engagement with state and regional partnerships. The Obstetrics Initiative is a Blue Cross Blue Shield funded project that is led through faculty in the School of Nursing and in our department, that has organized a statewide quality collaborative of 74 delivering hospitals. Their primary quality issue that they're looking at now is C-section rates, but there's the potential to use that collaborative to look at a variety of performance measures. A second one is we were very much involved early with the Regional 9 Perinatal Quality Collaborative, which I'm sure many on the call are familiar with. And then lastly, the Michigan AIM program has been, which is a hospital-based program aimed at reducing maternal morbidity and mortality by implementing safety bundles. And that has been really strengthened under Dee's leadership. So with that, I'm just going to put up our contact information, and I think I will welcome any questions. And I think with that, I'm also instructed to pass this on to Maria.
Thank you, Vanessa. This was awesome. While I'm transferring my slides, maybe there is a question or two for you. So
I don't think we have any questions as of yet.
Okay. Well, then everybody can see my slides. Yes, excellent. So with that, I'm very delighted to be here as the next speaker following Vanessa and the OB department's beautiful work that I'm familiar with. I am actually involved in, as you heard, I'm an associate professor in psychiatry and OBGYN, and collaborate with Vanessa and Kara and Lindsay and Alex, and so know them all. But I will bring you a different perspective to the same kind of questions and concerns, because we share the same concerns. We just have additional kind of complementary approaches, because I come from psychiatry predominantly. And so my approach is now thinking in addition to all the health policy and kind of this big picture, so what do we do now for the individual person, for the individual family? And that is in some way the work of Zero to Thrive that I co-direct, as well as I will tell you about MC3 Perinatal, a program that I direct. So let me briefly just tell you about Zero to Thrive. This is this program within psychiatry, really with this grand vision that we want to promote the well-being for the families and for all people in families to achieve their potential, the full potential, really from pregnancy through early childhood. We see this as the launching pad. It's not deterministic. Of course, life is across the lifespan. There is change and there is vulnerability, but also resiliency. But the early years, and we know prenatal fetal programming, we know that birth and postpartum are really launching pads for, both biological epigenetic changes as well as for psychosocial features that then kind of get carried forward. With that vision, our mission is really to span across research, so sparking scientific discoveries, promoting quality training, cross-sector initiatives that create breakthrough real-world solutions, really trying to be applied for the community and the persons that we work with, so that really it's to create well-being and resilience for families from conception to early childhood. Again, we think and we know from clinical wisdom and research that these are two-generation or multi-generation impacts if you can really promote the well-being in pregnancy and early postpartum. Here, just to highlight now what the strategic aims of Zero to Thrive are. So one is this community engagement, as I said, cross-sector collaboration, community participatory research, applied research to give both the voice to the individuals in the community, but to also create and evaluate programs to promote health in the community. Then research, we really strive for excellence in biopsychosocial discovery. We conduct mechanistic studies. We conduct clinical trials where we test novel psychosocial treatments, as well as test new technologies, how to now improve care for women and their families and the children. And we develop integrated care models in pregnancy and postpartum. Training, very important. We need to create educational programs for the workforce that work with pregnant and postpartum women, be it specialty care, so training in psychiatry or OBGYN, but also to primary care, like family medicine, nursing, midwifery. And we also create and conduct trainings in the community to promote resiliency of the community partners, so the moms, the dads, the children. And finally, our clinical service, similar to Vanessa, I'm a clinician. I lead the Perinatal Clinic, which is a specialty clinic for pregnant and postpartum mothers. We see yearly around 400 new patients and serve thousands across the year in return visits and clinical care with psychiatry, psychotherapy, groups, individual. In times of COVID now, the demand was even greater, and we did everything virtually and partnered with Alex Peel's team. When prenatal care went virtual, we were part of the team to promote the psychosocial supports for the women as they were getting fewer prenatal care visits. Okay, so with that, I want to kind of just set the stage. Vanessa really kind of led us and kind of showed us there are a lot of concerns, mental and you can approach this from the big picture. We know that mental health plays a big role. We know that 1 in 7 perinatal individuals have a behavioral health condition. Depends on the socioeconomic background, it might be even more prevalent. So it's unequally distributed. And we know that most of those who have a mental health condition are actually neither screened nor getting adequate care. So actually 75% of those who even get screened then don't receive treatment for depression. Maternal mortality rates are unacceptable in the US. We also know that they're unequally distributed, with Black women having much higher mortality rates than Caucasian women. And mental health is a major contributor to this fact. And with that, the question is, so why is mental health such an issue? Why are we not able to get a handle on this? And I would say, from my clinical experience and from my research, there are several contributing factors. One is, not equally distributed, but lack of access to mental health care. And therefore we need policy changes, we need insurance plan changes, because otherwise we have undertreatment, and that leads to some of these untreated mental health problems that then impact physical health, preterm birth, gestational diabetes, and other conditions. There is mental health stigma that is still widespread, and yes, we need persons who are influencers to speak out and address this and raise awareness. But that also, the stigma also leads to inconsistent screening, because maybe the women as well as the providers collude in minimizing and joining the underreporting. We have a lack of trained mental health providers. We have a knowledge gap among the workforce that is both in primary care. Folks are feeling not trained enough to then treat or address mental health issues, whether it's depression, anxiety, post-traumatic stress, or trauma, or substance use. The trauma-informed lens is also not consistently adopted. We know from clinical wisdom and research over the last 40 years that adverse childhood experiences and also adult traumatizations like interpersonal violence are major contributors to mental illness that can be triggered and aggravated in pregnancy and postpartum, and contributes to poor outcomes. There is institutional and systemic racial inequality within the health care infrastructure that also is, as Vanessa already raised as well, a major contributor to poor mental health, particularly among Black, Latina women. And then COVID-19 just aggravated everything. We have data from own studies published, actually with Sarah Compton. We did a national survey on 2,500 women who spoke to the fact how much their anxiety was rising, how scared and impacted they were in their pregnancy with the pandemic. Well, with that, what do we do? What are solutions? And what are the solutions that we are trying to bring to the forefront? I already spoke to some. Of course, we can do clinical service, and we do. We have a perinatal clinic from Zero to Thrive, and we have an infancy and early childhood clinic. So this is specifically mental health and wellness to children under the age of 6. That is a utilized resource in the past, and we really need to address mental health problems already early on, before they get cemented as mental health illnesses in our children and adolescents. We do a lot of trainings, both for mental health providers, substance use counselors, primary care providers, but also early child care providers, because they are the other group that touches young children and families. So it's another access point to serve families with young children under the age of 5. We, as I spoke, do a lot of community participatory research as well as programming, and of course then also basic science and research. So I want to highlight a couple just as examples, and we'll go from the highest intensity kind of therapies that we are co-creating as well as evaluating. This is actually a program that is a well-established program through community mental health. Infant mental health, home visiting has been around since the 1970s. And we, from Zero to Thrive, did a recent evaluation of this program to really showcase its effectiveness, both in an open, like pragmatic trial, but also in a randomized control trial, which is the gold standard of research for evidence building. And if you look here at the just kind of highlights of some of the outcomes, is looking at those who were in the treatment arm. So this is randomization. This were a total of 70 families. Half were in the treatment, infant mental health, half were in the control condition, which was treatment as usual, whatever they were getting. And these are families with young infants, young children. Those who were in the treatment arm, a year later, you can see this is at baseline, and this is a year later at 12 months. This is the treatment group, the yellow one. The green bluish one is the control arm. What we are looking here is emergency room visits, where the families go to use the ER as the place to get care, preventive care, or physical health care. You can see that initially, actually, the ones in the treatment arm use it much more than the ones in the control arm, but that it's dropping. It drops with the treatment. Actually, the use of ER visits, which often is instead of use with preventive care and primary care, is dropping, whereas in the control arm, it's really taking on, and families are not using preventive care in primary care, but they are using ER, which is much more costly. And we actually don't want this for our families. Here on this panel, on the right panel, you see how many percent are not following up with well child visits. And again, you see in the treatment arm or in control arm, in the beginning, at baseline, equally 18% of families use are not following up with well child visits. However, it drops in the treatment arm, whereas it doubles in the control arm. So again, good outcomes. Infant mental health is helping families to utilize care as they should, and it's saving cost for society. But also on the individual level, the parents' mental health, you see that they, in the beginning, start at the same level, where depression scores drop in the infant mental health home visiting arm, whereas it stays high in the control arm. Another application of the principles of infant mental health is integrating infant mental health clinicians in OB practices in prenatal care. So one of the things that we know, infant mental health home visiting is a wonderful tool. However, many moms do not land. And so the idea is, what if we already integrate such a clinician in prenatal care, and it's an in-person kind of a behavioral health consultant on site who can help connect to care. And here you have a study of 150 mothers in prenatal care who are basically half of them. This is a pragmatic trial, so it just was not randomized, but half of them were in this integrated infant mental health site. Half of them got treatment as usual at these prenatal care clinics. And what you can see here is the yellow line is the treatment arm, the bluish, again, the control arm. You see that at the beginning of pregnancy, they start unequally in terms of their depression. In fact, the treatment arm women are sicker, more depressed, but over time, the ones by 6 months postpartum, those who were in the treatment condition get better, whereas the ones who are in the control condition get worse in pregnancy. Their depression starts, and then they get slide down again as well. But over time, when you look at this difference, the rise versus the decrease over time, treatment makes a difference. And that's true here on this panel for depression. That's true for anxiety. And similarly, we find that when we look at emergency room visits with the baby, so instead of using well-child visits, but in the families, moms are going with the baby to the emergency room. You see that at the beginning, at 6 weeks postpartum, the moms in the treatment arm use emergency room 14%, but it drops, whereas the moms at 6 months postpartum, these moms the control arm use it much more. So again, an inappropriate use of emergency room and a very costly effect. Moving on, another way of reaching pregnant and postpartum women is speaking to the fact that I said that there are not enough perinatal psychiatrists and mental health professionals around to treat all the moms in pregnancy and postpartum with psychiatry. So what we are developing are support programs for OBs and family medicine docs and nurse practitioners who are with moms. And we developed and supported by the state a perinatal psychiatric access program that is helping primary care providers who work with pregnant and postpartum women to support them and support them and guide them how to best treat women. We are combining it with technology and also using technology-based screening and direct linkage to telemental health. So you see this program called MC3 Perinatal has a provider-facing offering where the providers like OBs and family medicine docs and can get same-day consultation on psychiatric problems, on how to treat and how to where to best refer. They get training and education and access to virtual toolkits. But there is also a patient-facing or mom-facing offering where through an app that could be screening and immediate brief intervention, as well as instant connection to telemental health if she chooses so, and also development of virtual toolkits for her of other offerings, as well as of self-care skills. So that's MC3 and HT2. It stands for high touch, high tech. Tech is the app, touch is the telecounseling that she has access instantly.
Dr. Music, I just want to remind you we're a little on time here.
Yeah,
just last one here.
Absolutely. This is my last slide, and then Lynette has a briefer version, so we kind of team tagged in that regard. Thank you so much. But I appreciate. I'm at my last. This is
Don't worry.
a last kind of a research program implementation where we developed attachment-based trauma-informed intervention with the community that builds resiliency, supports in parenting and mental health. And it's either for moms or dads or families in child welfare, military families, early childhood educators, depending on for whom this is. It's named differently, named by the community. So we didn't come up with the names of these programs. They're all under the Strong Roots program umbrella. And we are doing research on them. And they are currently not only as here displayed across Michigan, but also outside the state being picked up, because now we have evidence base that they are working these programs. We have even imaging data showing that undergoing this 3 months program, there are changes to your empathy circuits if you are in this intervention versus in the control group. So evidence-based programming developed with the community that are culturally responsive, that are addressing diversity and equity, and are really rolled out currently across the state of Michigan and elsewhere. And with that, I'm passing it on to Lynette, who is the strategic director of Zero to Thrive, and we'll take it from here. Thank you.
Lynette, you're on mute.
Thank you. That's been one frequent phrase of the last year, has it not? Good morning, everyone. I'm Lynette Beery, as Maria just said, the Strategic Director of Zero to Thrive. And as Rebecca mentioned at the outset, many of you probably know me from my previous role at MDHHS. Nice to see familiar names in the participant list. You want to put the next slide up, Maria, please? So I'm just going to quickly hit some high points on productive policies. Dr. Dalton and Dr. Music have set this up quite nicely for me to summarize a few things about some, I think, key policy takeaways from this conversation thus far. And then you get to hear from the real expert in our state, Amy Zagman. And I think one of the key things that we are doing and moving towards in this state is Medicaid coverage to 12 months postpartum. Dr. Dalton set me up perfectly for this with her slide about contraceptive use and declining birth rates among poorer women. Certainly that benefit of expanding access to insurance coverage certainly carries over to behavioral and mental health treatment. Obviously, if you lose your Medicaid at 60 days postpartum and you're on medication, sertraline, whatever for your depression, your anxiety, you probably are not going to be able to continue that medication. If you're on Suboxone for treatment of your substance use, your opioid disorder, you for sure are not going to be able to afford that 61 days and beyond postpartum. We hear story after story out there in the community from clinicians where women, were getting pregnant right away just so they could get to be able to continue that Suboxone. So we certainly don't want that. We don't want that anecdotally, and the research certainly bears out that the treatment for behavioral mental health disorders absolutely are women benefit from that improved access of care. MC3 perinatal. I think Dr. Music just told you why it's a good idea to have those psych access programs in our state. The other thing I want to touch on, having just mentioned substance use disorders, is that about 25% of the women that we in the MC3 perinatal consult on do have a comorbid substance use disorder. That's a fairly significant number. We have worked hard to make sure we have a dual enrollment process and connection protocol with the Michigan Opioid Collaborative. So we're ensuring that those women are getting the full gamut of connections. We do in Michigan, many of you probably already know, rank third in the shortage of mental health professionals. So this program is meeting a very urgent need for primary care clinicians, obstetricians, family practice who are seeing prenatal women to 1 year postpartum. Home visiting, this state is unique in the entire country for having a very robust home visiting system. We have a homegrown program, the Maternal Infant Health Program, that is evidence-based, that is Medicaid covered. All Medicaid women are eligible and their infants for that home visiting program, as well as federally funded home visiting, or MCV programs they're referred to, which includes Nurse Family Partnership, Healthy Families America, Early Head Start, I already said Nurse Family Partnership, Parents as Teachers. Infant mental health home visiting is considered a promising practice still. I would refer you to the PA 291 report on the web that goes to the legislature every year that talks about the positive outcomes that the home visiting system in Michigan has. Generally see improvements in breastfeeding, prenatal care access, smoking cessation, and referral for depression treatment of the women that are being seen across the state by any of the home visiting programs. These are not, this is self-reported data. And I would refer you to that report, but we are unique and we are held up around the country really as a model for what home visiting can be with appropriate inputs and resources. I do want to mention that infant mental health also is a clinically based model that truly is a preventative care model that works across that parent-infant dyad to prevent emotional, behavioral, and social and cognitive delays. And I think, Maria, given that we're short on time, I will leave you with Maria's slides that hit on some of the highlights of the outcomes of infant mental health. But we do see very positive outcomes, mothers with more sensitive parenting, toddlers with improved verbal skills. So definitely a program that we would like to support further in our state and see continue. The last thing I will note is infant and early childhood mental health consultations, or social emotional consultations, as they sometimes are referred to. This is pairing a master's prepared mental health professional with early childhood educators. It helps to prevent expulsions from childcare, helps to ensure that the childcare educator has the skills that they need to support that child's social emotional development and address behavioral issues. Has been evaluated and shown to have very positive outcomes, including things like ensuring those early educators stay working in the field longer and feel well supported. Next slide, Maria. And just very quickly, I want to touch on some of the key state partnerships. We've done a lot of work since COVID with the governor's office, working to support early educators, as a matter of fact, on COVID response and guidelines for early education and social emotional development with the constraints in the classroom with mask wearing and cleaning and getting kids dealt with who have symptoms, partnering with our partners in Department of Pediatrics at Michigan Medicine. We are currently working with BUDA, the Behavioral Health and Developmental Disabilities Administration, on trainings for substance use disorder providers to add to their toolkit for engaging their clients around parenting skills. Of course, as I mentioned, we've already mentioned NC3 perinatal. We are working with the Department of Corrections. We've worked on a few grants now looking for funding to enhance skills in ways in which to work with the children of those incarcerated when they are visiting their parents. And we do lots of trainings across the state, from the Judicial Institute to clinicians to the home visitors. And so with that, I have the privilege of introducing a colleague of, well, maybe I don't want to tell you how many years Amy and I have known each other, but a very long time. And here's Maria, my contact information as well, while I'm telling you about Amy. Amy is the executive director of the Michigan Council for Maternal Child Health. And many of you already know Amy, and really she needs no introduction. She is an amazing advocate for moms and families in this state. And with that, Amy, please give us an update on where things are at in Michigan.
Thanks, everyone. I am going to share my screen here and pull up a couple slides. I think that, let me just make sure you're all seeing what I want you to see. Sorry about this, thought I had it right there. Are you seeing the screen? Perfect. Great. Thank you all. Thanks for having me this morning. Thank you, Rebecca, for the invitation to join this panel. I really appreciate the opportunity to be the non-Wolverine in the room. I'll admit that right from the get. I am not a U of M grad, but really enjoy working with folks who are on the panel today, and really so many folks at the university and at Michigan Medicine as we talk about how to improve maternal and child health policy. I'm going to talk specifically more on the maternal and infant end today, but there are so many examples really of the great work that's going on. You heard some of them today. I could go on and on really about how the work that I do and that other advocates do are informed by the research and the practice improvements that have been birthed at the university. So I'll just give a little tiny bit of history. The Council for Maternal and Child Health has been around for almost 40 years. We do advocacy primarily at the state level. We do a tiny bit of federal advocacy when it's really important to outcomes in our state. But we were founded by a small group, and shout out to Pat Warner, who was the longtime executive director at CS Mott Children's Hospital. She was part of a very small group of people who saw the wisdom in having a group come together and support public health strategies with a prevention focus across the life course of maternal and child health. And so that's why the council was born. We have membership that includes CS Mott Children's Hospital and Von Voigtlander Women's Hospital currently, but we do not, unlike maybe other trade associations, sort of lobby for our individual members. We really are a greater good organization that looks at improving outcomes for maternal and child health. So we're grateful for our members and grateful for that, that initial leadership and vision. You can see, and I won't go into our entire policy agenda, which sort of covers everything that you could think of that might improve outcomes across maternal and child health. And I'll just say again that in almost all of these areas, I can give you an example in the over the decade that I've been with the council where these outcomes or these strategies have been informed by work that has gone on at the university. So, you know, I can think of so many people that I couldn't mention them today about partnerships that have happened. And really what I am always looking for when I'm talking to folks who've done research or in clinical practice at the university is thinking about how the amazing things that they have found can be scaled, can be sustained, can be spread across the state in a way that they potentially will have impact on population health. So, you know, a number of the folks that that Dr. Dalton mentioned are folks that we have worked with in the recent past to change Medicaid policy and to inform other parts of systems that are, you know, essentially the way in which people get their care in the state and the way in which we can impact their outcomes. And so I will also just say that, you know, the biggest issue for us in the council mirrors exactly what Dr. Dalton started by saying, which is, as we look at especially maternal and infant health outcomes, we are focused very intentionally right now on addressing the racial disparities in our outcomes. And so there is no other way to think about reducing Michigan's infant and maternal mortality rates than to think very intentionally about what are the strategies that actually will reduce our African-American and Indigenous infant and maternal mortality rates. We simply have to, all of us, in whatever facet of this work we're involved in, we really have to keep that at our core if we hope to make any progress. I probably don't have to convince this group about why maternal and infant health is so important, but oftentimes I find myself in a translational role with policymakers, and I am trying to impart upon them the importance of why we should focus at the earliest point possible, why we're always trying to move prevention strategies and appropriations and policy upstream. And it is important to understand that there are people in Michigan every year, women who die as a result of pregnancy or as a complication following childbirth, and that our maternal mortality rate is dramatically higher than the rest of the US and dramatically higher than other developed countries. And we have a lot of work to do in this space. That is also true of our infant mortality rate. And I'm not going to go into these slides in great detail, but I think that they tell two stories. This one, I'm going to give you infant mortality. The maternal mortality slides would be similar. Our infant mortality rate in Michigan really has not changed all that much. You can see that we've made very gradual progress. It goes up and down slightly, but we still continue to be higher than the national average for infant mortality, despite all of the investments and practice improvements that have been made in the state. And the real story is this one. The real story is that despite the drop in the rate, the disparity, the black-white disparity, the top line, the yellow line, continues to actually increase. So this is the difference between the infant mortality rate for white infants versus the infant mortality rate for African-American infants. And this is the challenge. And I don't know how to say it any more plainly than that. And I don't know how to emphasize for folks that every policy, every strategy, every appropriation that we work on really needs to be about reducing this disparity. I'll just say real quickly, I don't work for the state of Michigan. I certainly partner with them, as Lynette has alluded to. I will say this, that there's been an intense effort for over the last decade on the part of the state really to think about how to lead in this space. And if you're interested in knowing more about what the state has proposed, there is a Mother Infant Health and Equity Improvement Plan out that's currently being implemented. It includes state partners, it includes local partners. There are efforts going on at the regional level through perinatal quality improvement collaboratives. Dr. Dalton spoke to this and the fact that Michigan Medicine is leading the Region 9 perinatal quality collaborative, but there are these collaboratives exist across the state. It's the way to bring together regional partners and really think about looking at very intentionally at local data and local strengths and identifying what needs to change locally to improve outcomes for mothers and infants. If you are in another part of the state, maybe you're an alumni or not currently operating out of the university and you're interested in being more involved in this work, I would encourage you to find your regional perinatal quality collaborative and be involved in this. There are work groups associated with the plan, one of which is around policy and advocacy. So, one of the intentional efforts really is to bring together all of the partners who do work like my organization does and think about what are the policies and legislation that we can support to implement the plan. So what's happening right now? I said I wasn't going to talk about the federal level, and I'm really not, but there is a great deal going on nationally with regard to understanding the drivers of maternal and infant health. And we are hopeful that some of those efforts will be fruitful because they usually result in increased federal funding and increased supportive policies that will help us in the state. Certainly at the state level, in the last couple of years, in part because of the plan that I just talked about, and in part because of this very intentional effort around dealing with the racial disparities. There's been increased interest. Last year, prior to the pandemic, Governor Whitmer highlighted in her State of the State, she highlighted this crisis of maternal mortality, and she really used it as a frame to talk about the need for implicit bias training at all levels. And that has resulted in rules through the Licensing and Regulatory Affairs Department that require implicit bias training for all licensed health professionals. This is crucial. I think it's going to be a tremendous help to understanding what we can do in both maternal and infant care to really start to help practitioners, help those who are going into practice understand their own unconscious bias and what they can do to address it. I'll also say that last year, the governor really led with an executive budget proposal called Healthy Moms, Healthy Babies. Lynette already spoke to the fact that extending Medicaid coverage to 12 months postpartum has tremendous benefits for women in the postpartum period that we know is so important as they're, establishing a new family and recovering from birth, and hopefully by extending Medicaid coverage, we can address some of the underlying causes of maternal mortality and morbidity. Michigan, in our current year budget proposal, the legislature did agree to this Healthy Moms, Healthy Babies proposal, and the funding for the extension of the Medicaid coverage is included. There are some federal hoops that we need to go through as far as getting a state plan amendment from the Centers for Medicaid and Medicare, and those are in progress. But Michigan is ahead on this. This is a big national conversation about extending Medicaid coverage through that first year following pregnancy, and we are in a really good place, I think, to make this happen and hopefully see the downstream impacts of that in years to come. There is also in that Healthy Moms, Healthy Babies, the investments that were made, an extension of the behavioral health supports, and you've heard at great length today about MC3 Perinatal, which is part of what the state is investing in here. And I think I don't have to go into all the reasons that is so critically important. That's an example of taking something that really has been developed by Dr. Music and others at the university and thinking about how that can be scaled across the state to the benefit of pregnant women and to the benefit of providers that serve them, who, as Dr. Music pointed out, they want to be able to help their patients. They need expert consultation to be able to do so. And then I'll also mention that there's a whole list of investments that have been made recently in home visiting, and Lynette did a great job of highlighting what a strong system we have in the state of Michigan. It requires investment. There's a number of federal sources coming down, but we need the state to be actively engaged in making sure that if we're going to have a variety of home visiting programs available on the ground and available to families in the community, that we help them navigate those programs and get connected to the program that can help them achieve what they're looking to achieve with their family. Every parent, every family wants to create a nurturing environment for their infants and their children. And home visiting has shown great evidence at being able to do that. It's all about getting folks connected. I'll also mention we're at the beginning of a legislative session in Lansing, so there aren't a lot of bills to talk about, but Senator Brinks, Winnie Brinks, did just introduce a bill last week, Senate Bill 252, that would codify the postpartum coverage. So the money's been put in place. I talked about the fact that the administration is pursuing Medicaid policy to make the postpartum extension a reality and bring down the federal Medicaid match. But Senator Brinks is interested in making that a more permanent part of our offerings through Medicaid, and that would happen through Senate Bill 252. I'm not going to go over this in great detail, but I do just want to say, if you're very interested in what you can be doing to support overall early childhood policy in Michigan, there's an effort kicking off. It's gotten off to a little bit of a slow start because of the pandemic, but a broad-based effort across a number of organizations, including the council, called Think Babies Michigan. We're interested in making this the best state to have a baby and raise a child. And you can read there the the policy agenda items that we have that are relatively broad, but inside each of these areas, there's groups meeting and coming up with very specific policy agendas that we're hoping to move over the course of the next 5 years to really improve the lives of infants and toddlers in the state. Everything from the security, the financial security that those households have, to the access to childcare, to access to all types of developmental and health supports, not the least of which I would say are the types of behavioral health supports that Dr. Music and Lynette spoke to today. So I would just encourage you, if you're interested, we're trying to build an army, build a huge coalition. And if you're interested, I would strongly encourage you to connect through Early Childhood Investment Corporation. The link is there, and become part of our Think Babies collaborative. This is a way to receive timely opportunities to engage in grassroots advocacy that will benefit families across the state. And I think with that, I am happy to turn it over to Rebecca for questions. Hopefully I didn't talk too fast. That's the gift and the curse of a lobbyist, is sometimes we talk too fast because we got to get it in. So if you're really interested in the work that the council's doing, I'll also just offer that we do a weekly e-newsletter, and we'd love to add you to our list.
Thank you, Amy, and thank you to the entire panel for the very comprehensive overview of maternal and child health policy and research here in the state. As Amy mentioned, we'll move to our questions and answers. We have a few that have been asked in advance, so we'll try to get to as many as possible. If you do have additional questions, feel free again to put those in the Q&A feature. So with that said, one of the questions that was asked, there's a couple of questions and I'm going to try to pull them all together. So with COVID and with the, just in general, the issue of a lack of access or participation, the question of telehealth has come up, and I think from each of your perspectives, how has that played a role in the delivery of healthcare, the delivery of psychiatric care, and what are some of the positives, the negatives from? I'll start with Dr. Dalton and kind of have Maria and Lynette follow that up with a combination of the psychiatric care model.
That's a great question, and I kind of fumbled my introduction to COVID. COVID forced us to do some stuff that we knew we should do. Part of that, especially around prenatal care, is prenatal care lends itself to virtual or even some home screening really well. I would say that it's a blessing and a curse, meaning that it pushed us to do something. But we probably didn't have enough prep time to make sure that equity was maintained through this. Obviously, for some people, for a variety of reasons, that model doesn't fit quite as well for them, and we didn't have a choice during COVID. On the flip side, it really helped us look at ways that we could enhance access, COVID even aside, be that childcare issues, and all we really needed to do is check a blood pressure on someone. We have now set up systems to be able to deal with that. And, again, Alex Peel, who is redesigning our prenatal care program, a lot of the lessons we learned during COVID are applied to these sort of more tailored prenatal care approaches. But again, I think the question, and maybe Maria would like to comment on it, that we recently talked about is that I think we didn't have a lot of prep time. And so it's unclear to me whether this actually has the potential to worsen disparities, which I think Amy talked about. I mean, that is to us, really, really at the forefront of almost all of our work right now.
So I'm gonna just second that the technology is not the problem in terms of the, technical piece, particularly in psychiatry, because we don't have any, we use ourselves as the medium through which to deliver the care, and we don't need any additional, particularly in the outpatient world. So we were very able within actually 1 week to transfer all psychiatric outpatient services in perinatal, individual group therapies, psychiatric care into the virtual space within 1 week. So that was not the issue. As Vanessa said, the benefit is that many obstacles, particularly in the perinatal period, like transportation, childcare, being postpartum and feeling just exhausted, not wanting to go anywhere, or not having a ride, or having other children that you have to bring, all that fell away. So we were actually much better able to access some patient populations, plus to get the partners on the screen as well, and do actually family-based works, almost like home visiting. And we also had some access to seeing how the patient lives. And so in some way it opened certain opportunities. The biggest obstacle was bandwidth, wireless access, and also having maybe the tablet or the computer. So I think that there are some technical, but really this should not be the issue. The technical know-how we have, we just need to put resources out, be it in rural areas, being it disenfranchised patient population groups. And again, equity issue was a major issue. So in many of our research implementation pragmatic studies, we actually turned it around and started to provide the technology and access to Wi-Fi as part of the programming, that it has to be given out as well. So that's my perspective.
Amy, from your perspective, has there been any policy need for reimbursement on telehealth, or and I think in relation to what Dr. Music said on the technology side, as someone who lives amazingly only 15 minutes from Ann Arbor, who I have internet issues, I can't imagine, just the cost and other things. Is there any work happening in that space?
Yeah, there, certainly I think in the same way that practitioners pivoted very quickly, a lot of the insurers, be it the state under Medicaid or under private insurers, pivoted their reimbursement policies really quickly. And I think you're seeing from most of them some interest in carrying that forward, not surprisingly, because to Dr. Music's point, better outcomes, right? Fewer missed visits, that kind of thing. So I think as far as reimbursement, there's good trajectory as far as policy. It doesn't get around the issue that you just mentioned, Rebecca, that it's built off the idea of being able to do virtual visits is built off of needs that exist as from an infrastructure perspective. So I think there are some conversations a little bit outside my wheelhouse of conversations going on in the tech and energy space and the legislature, thinking about how we can use some of these federal stimulus dollars that are one time really to make what are essentially one-time investments in the infrastructure in the state. And I think those of us, even that isn't necessarily an area that we usually find ourselves advocating for, have to understand that that is underneath all of this for us, right? That's underneath the ability to provide these services, be they, online schooling, or whether it's a medical visit virtually. We really need to think about making that investment. So I think, to the extent, again, that anyone is on today that is involved in a decision-making role or wants to be involved in advocacy, I think that is a constant for all of us to be saying, if we're interested in equity and we're interested in being able to keep some of these lessons that we have learned from COVID, we really do need to think about having broadband access across the state. And to Maria's point, any investments that we can make in making sure that the technology and the hardware is not an impediment or a hurdle for any family to participate. I just think those are investments that would reap benefits across. So I think certainly you make a great point, and it's something that continually comes up no matter what venue I'm in.
Okay. Okay. So from one of the, as someone, I actually have a 1-year-old. So I had a baby right before COVID started and utilized the home service program. And it was great. But I do remember thinking I had to take the baby for the 1-day appointment. And then, the person came to our house, I think 3 days later, and I don't have any issues related to, resources, but there was, this is my endorsement of said activities, because it really allows you to feel much more comfortable at home and feeling much more comfortable with the baby. But from your perspective, Lynette, with the MC3 program, what is on the horizon, and what are some of the challenges from the healthcare perspective? What is kind of preventing clinicians from promoting that program or moving that to the next phase?
Well, we're working hard right now, Rebecca, to engage every perinatal provider in the state of Michigan, and we have reason to believe we're gaining traction. I think from the clinical perspective, they're busy, right? It's been a hard year, and people are just, we hear a lot about, and have done, Dr. Music and others have done a lot of work around basically listening to what the clinicians' needs are and trying to help them, frankly, with their own self-care. Because, obviously you got to take care of yourself before you can turn around and take care of families. So I think, frankly, that has been a bit of a barrier. At the same time, people, we are hearing from many, many people that, that MC3 perinatal is a lifeline, and we're getting many, many more clinicians engaged and enrolled. And, we, with the governor's Healthy Moms, Healthy Babies initiative and the funding that has afforded us, we have been able to reach more folks. Yeah. Does that answer your question, Rebecca?
Yes. Yes.
Yeah.
Yes. I more wanted to ask it to endorse the program, because
well, bless your heart. We appreciate that.
Yes. I think that at first it was kind of, I was worried about cleaning my house. That was my biggest problem.
Right.
Or someone came in, but it really was exceedingly comprehensive. And I think with some of the apps that Maria talked about and some other activities, I think that those are really interesting. Can
I just add on
please
one sentence? Just to amplify what you just said, we are hearing from the moms and the families also that the virtual space gives them more flexibility to use the resources more at their need. And we really, but in psychiatry, we have to also get away from these old traditional models of what is psychotherapy look like, once a week, an hour, or maybe therapy is every day, 20 minutes, I check in with someone, or, 3 times a week, or this week I need you more often, and next week I need. So thinking about a holistic care coordination therapy, addressing both my mental health, my coping, my parenting issue, and really kind of developing new ways of thinking about telemental health, telepsychiatry, and resilience building for the communities and the providers, as Lynette said. So it's really that's the if there is something on the horizon that is like a positive, the novel approaches and the innovation that will come out of this, and new funding structures, and thinking about how to fund mental health that will stay with us, I think.
Okay. So I know we're running up against the time frame here for our ending. Any last minute thoughts from any of you? I think there's a few extra questions, but I think most of them were covered in most of the presentation. So any last minute thoughts, Dr. Dalton?
I actually just wanted to comment or make a follow-up comment based on something Amy said that I hope came through, but I think needed to be articulated a little bit more from our work's perspective, and that is about the importance of really challenging conversations we need to have around the underlying causes of racial disparities. I alluded to this a little bit, and we spent a lot of time this year really looking within ourselves and the way that we deliver care, the way our systems are set up. All of us have gone through implicit bias training. My chair is super committed to this. We've had a whole year of curriculum. It is, I want to make the point that we have to recognize that racial disparities that we see in outcomes are not because of income, they're not because of health conditions. Even when those things are adjusted for, differences exist. And there's a lot of work that shows that there is also variation in where you get your care. And what that suggests is implicit and systemic racism. And so these are really hard for all of us that love our work and to grapple with, but I just need to sort of articulate that because I think that's what we have spent a lot of time and focus on this particular part of our work. But so thank you, Amy, for calling that out.
Thank you, Dr. Dalton. Any last minute thoughts, Amy, Lynette, Dr. Music? Okay, great. Well, I can't thank each of you enough for serving today on this panel, and as well as I want to thank all of the participants. If you're interested in sharing this presentation, it will be posted to U of M's public engagement page, which I included the page in the chat, but it's just publicengagement.umich.edu. It will also include links to any websites that were mentioned in today's presentation. So on behalf of our Vice President for Government Relations, Chris Kolb, and the University of Michigan Alumni Association, I want to thank everyone for participating today and to have a good rest of the week and to enjoy the last couple of days of this warm weather. Okay, thank you all.